Okay, great, that works. Good afternoon, everyone. My name is Mark Hughes. I am Cindy Rushton in the back, co-chair of the Hospital Ethics Committee. So this is our first Ethics for Lunch of the academic year, so welcome. We meet on the third Tuesday of every month. This is a joint venture by both the Ethics Committee and the Department Institute of Bioethics. I will just run through some of the CME slides just to situate you to what we do here. So first of all, this is designated for 1 credit hour. So you can give you the code to get that, or you can go to the CME website. We have disclosure. I don't know if anyone today has any conflicts of interest, and I don't anticipate use of off-label medication usage. They'll identify that themselves. We open this for the whole hospital community, any staff members of the hospital, as well as community members. And this is really the way to help you think about patient care, especially the ethical issues that come up, really fostering communication among the policy stakeholders. So as I said, nobody has any concerns with conflict of interest today. And what we're going to be talking about are the use of antibiotics and where that becomes a concern about resource allocation. So these 3 objectives, and I'll turn it over to our panel to discuss more about that. If we do mention, we use hypothetical cases that might be based on a real life case, but it's to be identified. But if there is any chance that anybody talks about any particular patients, we expect that there would be confidentiality as part of the CME requirements. And for getting credit for today, that is the number 1-844-980-1555. And the code today is 57920. That should send you a message thanking you for your participation. I need to keep that up for 57920. Okay, and then as I said, you can go to the CME website as well. All right, everybody here is infectious disease affiliated in some way with ID. So they have their own bias to talk about that. And I'm going to turn it over to Chelsea. The podium.
Yeah. All right, well, welcome everyone. My name is Chelsea Modlin. I'm a relatively new faculty member in the Division of Infectious Diseases, and I'm really happy to be here with my colleagues, Kate Nzar, who's our wonderful infectious disease pharmacist, and Olivia Cates, who is a part of our oncology ID group. Just talking about some of the issues we encounter on a fairly regular basis and some of the kind of background but level considerations that go into a lot of the clinical decision making that we make on So this is a composite case. It's not any one particular patient, but is kind of captures a lot of issues that we see on our clinical practice. An 84-year-old woman, she has dementia and multiple chronic co-morbidities, who's coming in with failure to thrive, recurrent aspiration, and prior to admission has kind of a minimally communicative baseline living at home with her family. She had a prolonged admission with a lot of ups and downs, received multiple courses of 7 to 14 days of antibiotics, and then at some point during her hospitalization developed progressive renal failure. And after discussion with her husband, who's her primary decision maker, underwent arteriovenous fistula placement in anticipation of starting on antibiotics. So the fistula was created by the vascular surgery service, but complicated by delayed wound healing. So they swabbed the surface of the wound, and what came back are 3 what we would call kind of multi-drug resistant or drug-resistant bacteria. It doesn't really specifically matter exactly which kind, but these are 3 different types of bacteria. There were required 2 bacteria They require 3 different antimicrobials in order to treat. So based on this result, the vascular surgery team comes back and says, cannot rule out that there's a subclinical infection causing the delayed wound healing, would start antibiotics, but would defer a selection and duration to our infectious disease colleagues. And then the infectious disease team comes back and says, well, if you don't think there's infection, we don't recommend antibiotics. But if they are strongly indicated from a different specialty perspective, would need 4 to 6 weeks of treatment for endovascular infection and disease and ongoing care. So both recommendations are discussed with the husband who requests antibiotics to be started as part of both doing everything that we can. And what I just kind of want to highlight, because there's a lot of information, is that the role of antibiotics in this case is unfair. We don't have a lot of data that supports its use or supports not using it. So it may help with wound healing, it may not. We just don't really have a lot of the background information we need to make that specific determination for the specific patient. We do know that this spectrum of antimicrobials will increase selection of drug-resistant bacteria in the normal body flora of this patient, which has already probably been fairly exposed to antibiotics she's gotten hospitalization. But whether this is clinically relevant, it's hard to predict whether or not this will actually have an impact on the long term. And then this is just kind of a little bit more medical background, but these are the 3 antimicrobials that we would use to treat these types of bacteria and fungi. All 3 of them are relatively high cost. They're very broad spectrum, meaning they cover a wide array of bacteria, and then would require IV administration through, if the patient were to leave the hospital, or OPAT program, which stands for outpatient parenteral antibiotic treatment. All right, so I'm going to turn things over to our panelists. We've got kind of a series of discussions and then a little bit more of the case and then discussion questions again. But when you have conflicting recommendations from teams, how do you go about talking with patients, with their family members about how, how do things move forward and how do you make a decision in that for
All right. Green for don't go. Red for go. Is how this might. Awesome. Thanks, Chelsea. I think we were talking about this a little bit before we even got started, but probably the first thing that comes to mind is like that guy in the Lord of the Rings, where he's like standing there in the rain and he says, "How did it come to this?" It's kind of how I feel about this situation. There's clearly like a long backstory leading up to the point where 2 different teams are asked to weigh in and take care of a 84-year-old patient who's minimally interactive even with her close loved ones, but who's now been set up for long-term hemodialysis with a surgery and is dealing with a surgical complication after that. Right. And I think actually one of the reasons it's probably very hard for anyone to make a decision at this point is that a lot of people weighing in now might be very frustrated with the situation that's being presented to them. So like the infectious diseases team is called, and this is the situation. My first thought, and I'm guessing maybe others' first thoughts would be like, well, this shouldn't be the situation. Please go back and handle it differently last month or 2 months ago. Such that I'm not confronted with this question now, which, as you all know, is not a realistic approach to the current problem. But then I think when you've decided that you shouldn't be in this situation and you shouldn't be confronted with the problem that you're facing, there's a little bit of like a diffusion of responsibility, right? Like, I would never allow this to happen, therefore, I should not feel guilty about my inability to resolve the problem now, which I think is a potential problem for this patient. And then I think you can kind of see that in the reaction of the team, which I can admit is the infectious disease team, at least, which I can admit is not unusual to say, here's my opinion, right? I've given you my opinion. I don't think there's an infection. I personally wouldn't recommend antibiotics, but I will give you an additional piece of information that's conflicts with my actual opinion. And it's really kind of like a scare tactic, if you think about it, right? Saying like, if someone forces you to give antibiotics, just so you know, it would have to be 6 weeks of 3 drugs that cost $1 million. And ruin everybody's life in the process of administering it. And like, you have to, if you're gonna put something like that into the conversation or into the medical record, I think you have to think really carefully about what's motivating you to say that. Because to me, it feels like the intention of saying something like that is just to scare them. Is to say like, you think you want this, well, let me tell you what, you don't want it, because look how unpleasant it's gonna be. And then guess what? They do want it. Yeah. You put out that option, now they want the option. Fine. So yeah, I guess my first caution here would be like, avoid advocating responsibility for addressing a problem just because you don't like the nature of the problem. You think you could have avoided creating it. That. And then my other thought would be, don't offer recommendations to frighten people. And then my last thought here is like, I actually think that there's not like no opportunity to compromise here. One thing that we run into a lot in ID is we do have a lot of guidelines about duration of antibiotics. And I think we often will say things like, well, if you insist on taking this seriously, you have to take it 110% seriously. You know, you're going to force me to treat this infection. I'm going to force you to treat this infection according to the highest possible standard. That's not always, I think, necessary. You know, I think maybe it feels a little ethically ambiguous to say I'm going to do a compromise plan that doesn't reflect the best standard of care. But for like the specific patient in the specific scenario, maybe a reasonable compromise plan is to choose one of those 3 drugs, targeting whatever you think might be the most pathogenic organism, I think that's gram negative. And for that for fewer than 6 weeks, make sure there's a blood vessel there, but like, do I really think that I want to call this like an endovascular infection because there's a blood vessel there, when I also didn't think it was an infection at all? But yeah, so perhaps more openness to compromise, even when it means deviating from guidelines. And personally, I think that the right thing to do is almost never decided like a technicality, right? Technically, there's a blood vessel.
I think those are very fair points, and then, typically, what happens is pharmacy is even called in after this debate has happened. And then I'm presented, well, Kate, they want to go forward with 4 to 6 weeks of antibiotics, so what should we do? And I think at that point, then the conversations on my end become the same, like, are you sure we want to do this? Maybe we don't need to give it this long, like, can we talk about this? But I think sometimes, and I agree, I think there needs to be more of that conversation. Can we do 10 to 14 days? Like, you're standing here telling me that you don't really think it's effective, but we're pushing for all of this. But then I think on the flip side, one of the things that we need to do when we're talking to the family members and such, and this is where I tend to be a little bit more involved directly with the patient too, is really present them with all of the issues with the antibiotics. You know, looking at what's up there in terms of antibiotic selection, this is 5 infusions per day. They are going to be on an infusion pump for this long. This could interfere with quality of life at this point. Do you truly have somebody who can administer all of these infusions? Because I don't know if you have the appropriate coverage that somebody is going to come to your house this many times a day to administer each one. Followed by, these are not benign medications. There are adverse effects associated with each of them. And this is what could happen. And really have a risk benefit conversation with the family in terms of what they're really facing at home if it does progress to COVID.
Yeah, in my experience, a lot of the families and a lot of other teams think of OPAT as a service where someone comes to your home to give you the antibiotics. often when we talk to the patients about OPAT, they've already been told by the team, a nurse will come to your home and give you the antibiotics. A nurse will come to your home once a week. They actually will not give you the antibiotic during the visits, but they will collect blood from you and send me a little email in my chart to be like, this person is alive. And that's pretty much it. You will actually be managing the antibiotics yourself, you or a family member or another support person that you have to identify to do all of that work. The other thing that people kind of imagine, I think not quite right, is when Kate said 5 infusions per day. That's not 5 touch points per day. That's 5 infusions, each of which involves taking the medication out of the refrigerator and letting it come to room temperature, doing all little doohickeys or whatever to hook up the thing, you know, I don't actually know all those things, but it's more than 5 touch points. And because the process takes time, even 3 infusions per day, so 8-hour interaction with the antibiotics means people can't sleep for more than 6 hours. Because you have to get up, take the thing out, wait, hook it up, wait for it to infuse, unhook it, flush it, put all the stuff away. So even stuff that sounds like, okay, worst case scenario, I could do deep sleep because I could sleep for 6 hours. No, that's 4 hours of sleep that you're getting. That's horrible. So I think it's a much bigger burden than people expect or are prepared for when they talk about outpatient antibiotics. On the flip side, though, we also get a lot of patients who are like, I couldn't possibly handle that. I'm like, don't worry, okay? You can handle it. Any person in the hospital potentially qualifies to go home with outpatient antibiotics, and many of them do. They all seem to handle it. So can you. People have the capacity to do this. They have the technical ability to do it. They can learn this skill, so they shouldn't be afraid. But it's a big burden that we put on them, and we should not act like it's.
All right, so what I'm hearing is transparency and kind of being clear about really capturing anticipated benefits and anticipated risks, which kind of talking about biases, one of mine is that I feel like often providers, both in ID and outside of ID, don't really adequately conceptualize a lot of the risks that come with antibiotics. It's kind of viewed as this almost like neutral thing that we're able to provide that may or may not help, but it's probably not going to hurt. And that's a perception that our stewardship group is doing a lot to kind of try and shift away from, because we are kind of increasing recognition of some of the negative outcomes of antibiotics. And it gets back to Olivia's original point, which is that it feels like infections are often kind of treated in this binary way. Like you're either infected or you're not. You need antibiotics or you don't. And because there's this dichotomization, there often is an underappreciation for like how gray and messy a lot of these cases can be. And so, you know, just seeing that there are alternative ways of exploring, and that not decisions need to be made like right this second. You can, you know, either start antibiotics and see how they do, or not start antibiotics and see how they do. Those options are available, but for some reason, when infection is involved, there's this kind of urgency to start something. And oftentimes that leads to antibiotic use that has been, let's say, infectious perceived. Yeah, you can say, right? You don't even know. We find bacteria attached to something. But then because of that, you know, we use terms in the stewardship space like antibiotic misuse or inappropriate antibiotic use or rational antibiotic use. And these are really value-laden terms. They have a moral weight to the terminology that we're using. And so by kind of putting these labels on these decisions, it kind of gives them a lot more kind of, I don't know, that like feeling you get when you're trying to make these decisions prospectively.
The actual stat is that 1 in 5 patients who are given an antibiotic will end up having a disease with some sort of antibiotic associated adverse event. So it is not an nominal risk anymore. We know what that number is, and that's really why we're trying to change that stuff with it.
I'm gonna open it up to the room, see if anyone has any questions or comments just on this part of the case. Please.
So you talked about transparency with the family. What about the issue of the cost of the medication? Would you share with the husband? These are going to be very expensive medications. Is that part of the benefit?
So it absolutely can be. I was just looking at the antibiotics that Chelsea put up there, and raw costs to this institution for 5 infusions for the 3 that were on normal doses for those 3 antibiotics are probably close to $3,000 per day. And that's our cost. That's not then the patient charges, that's not delivery to the home, that's not all of the other supplies that go with the medication. Being that they're both in their mid-80s, I would assume that there's some sort of Medicare or Medicaid involved here, which means that there's going to be very, very little coverage. And then you may run into situations where some are covered, some are not. Maybe we'll allow this for this much time. And then it really does become a very difficult conversation of which one is the most important, which one should we pick, which one poses the lowest risk for adverse events, and try to find the balance, which is awful considering we're still completely unsure that there's an infection involved in the first place. But in a situation like this, I don't shy away from having the cost conversation, no. Because then on the flip side, if there is an infection and we're treating it, not treating it enough is also problematic too. And just giving enough exposure that we run the risk of complicating resistance further in the future.
Yeah, I think this is still, it's an increasingly common practice at OPAT, but it's still kind of expensive. There's a lot of extra resources that go into doing it. What makes it, I think, very hard to even think about the ethics of considering the cost in this situation is that we also don't think the treatment is necessarily needed. Right. So we kind of already go through our professional practice knowing, hating, but knowing that patients receive a different menu of treatment options based on their ability to pay for non-covered aspects of their care, which sucks.
Assuming this is a real case.
Yeah.
It's the first couple of minutes. I guess I'm just curious to hear from you as ID and you as pharmacy. You know, if you talk about how long this case went on, it's very complex, it fell into our laps, and I don't know if you were personally involved, but just be hypothetical. But would you feel comfortable in your practice synthesizing the data and saying, I'm sorry, we would recommend that we treat?
Yeah, and I actually think that was the recommendation from the ID team. What happens to those recommendations as, we're not the only guys that can talk to the patients, you know, they'll let everybody talk to them, probably for the best. But so in this case, the infectious disease team gave a recommendation, the vascular surgery team gave a conflicting recommendation, and then the primary general internal medicine team synthesized those 2 recommendations and presented them both to the patient, and then did some kind of like a shared decision making with the patient's decision maker, the husband, and then came back, the infectious disease team saying they had chosen option B. ID left the window open for that by saying, we don't recommend treatment, but here's what the treatment would be. Mistake, don't do that. But also I think there's something going on in this case that's very interesting that I would call autonomy gone wild. You know, we're letting the patient's decision maker make a lot of decisions over the course of this hospitalization that in retrospect, we're kind of like, maybe this wasn't really all of the decisions, maybe these weren't in the best interest of the patient. We don't know a lot about the patient's preferences and goals, but now all of a sudden we're looking at it and being like, whoa, 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 you know, this train has to stop here. And something I worry about in complex cases like this, where there's been a series of like handoffs as patients admitted over a long period of time, a lot of different teams have been involved in their care. The one constant is the caregiver, the husband. I think that the responsibility shifts disproportionately onto that constant person who's the caregiver, who's not the medical professional. And it's easier and easier over time for new teams that get involved to say, this was already decided, the husband's in charge, the husband does it, blah, 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 blah. And I think we give the decision maker less and less support, the more time we sort of change hands or yield responsibility or sort of lose interest or become frustrated by the case. And now this decision makers in the position of making challenging decisions that we think are maybe not the best. So I think that's maybe a little too much autonomy, not enough care or supportive decision making. And that it might be time for the team to take some of the responsibility back, just like you said, and give a more concrete recommendation. Then I should become to resolve that recommendation with other teams who are kind of trying to do the same thing.
I'll just add, I think based on seeing cases like this, I generally try to like touch base with the vascular surgery team before I go see a patient like this and speak to their family members to understand where they're coming from. Like, is that recommendation because they found the bacteria and, you know, bacteria equal antibiotics, or do they genuinely think that antibiotics play a role in wound healing kind of based on their experience, based on seeing things? And you'll get a mixture of answers that can also kind of help differentiate between, like, you know, what falls within their realm of expertise and what is kind of a reaction to something that feels less familiar for them. So I'll often try to do that before rather than after, so that when I talk to a patient, my family member, I can say, I've talked to the surgeon, this is kind of what we can do together, so that the onus of responsibility for the decision doesn't fall on an elderly gentleman, and instead is coming from teams that are working.
Yeah, the consulting team has many patients, patient of course, but then also the surgeon, yes, and it's also the primary team.
All right, I'm going to move things forward just a little bit here. So this kind of goes along with the conversation about the husband's involvement in some of the decisions. It's putting this in a slightly broader context. So we talked about the immediate problem, the short-term idea, but then trying to keep, you know, remember that there's a lot going on outside of this potential and possible infection. So when talking with him about kind of goals, the idea, what ideally would happen is that she recovers from this acute illness and returns back to her previous baseline, is able to go home with home health services, and that attempts to engage in kind of end of life or hospice related discussions have been fairly unsuccessful. He's just not ready to start having those conversations. So broadening out from just kind of short-term considerations to more long-term as well, you know, how would we think about antibiotics in this broader trajectory, which Olivia has already mentioned, and how do antibiotics kind of play a role in ongoing goals of care discussions? Since we kind of view them as these like very short-term interventions, and those kind of rarely work together with more like sustaining measures, and so they kind of fall in this gray area often of not something that frequently complications we have how.
Yeah, so I think late life or end of life care is like a good context for antibiotic use, and it's become kind of a target for antibiotic stewardship. Because I think a lot of the antibiotic use during this period of people's lives is perceived as misuse, at least. It's difficult. First of all, I think people tend to see infections as reversible, right? I have an infection, I take the medicine, I no longer have an infection, and all of the negative effects of the infection that I experienced will also go away, right? I won't be coughing anymore, and I will be able to do the same level of activity that I was doing before my infection. That's not always reliably the case. First of all, people continue to age over the period if they have an infection. No one ever goes all the way back, unfortunately. And second of all, some of the impacts of an infection in my body are not reversible even when the bacteria are cured or removed from the body. So, I think shifting the expectations of what antibiotics can do in situations like this is very important. Antibiotics are not necessarily going to help with the goal of restoring this patient's previous level of functioning and getting them home. If anything, because of the high infusion burden, they may obstruct that goal. It may not be feasible to do the treatments at home, making more time in the hospital, potentially more conditioning. And then I think another thing that the consulting teams could probably spend a little bit more time helping with those, explaining the potential usefulness of antibiotics in late life or end of life. And sometimes when people sort of hold their you transition to comfort, the consulting teams disappear, right? Like, oh, no, done. No longer my problem. I save lives. I have nothing to do with this. But that's not the case, right? First of all, you know, save all lives. And second of all, part of our job is also to support people in the end of life with things like comfort. And so I think it's important that we give recommendations and explain how antibiotics may or may not impact comfort and how antibiotics may or may not impact longevity. And then the last thing that I think antibiotics sometimes do for people at the end of life, which represents a compromise, is give people more of a sense of agency. Right? There are a lot of things that people can't decide or can't control at the end of life. For example, I think unfortunately this patient's husband can't control whether it is time to have a conversation about dying or not. It is time, right? Yeah. Some people are not ready when the time comes, but the time has come anyways. So I still think that it's important to try to pursue that conversation with him and help him become ready. But sometimes people can make decisions about things like rats. And I think the next set of slides is about the community cost of those decisions. But one thing that supporting families choosing to use or not use antibiotics does is gives them an opportunity to express some agency during a period when you otherwise have very little control, very little.
All right, and I guess so along those lines, I'm curious to hear your guys' thoughts on the role of time-limited trials for antibiotics. And whether this is a case that you think that might be a good compromise, and in your experience, whether time-limited trials work with antibiotics.
Oh no, I think they're unmasking my intellectual dishonesty. Comfortable experience at ethics for lunch, but yeah, I think there is probably a little intellectual dishonesty going on with time limited trials, because usually that's just like, allow me to prove myself, right? You know, I'll give you this, but I already know it won't work. And then you'll have to agree with me.
But it's now we're already doing like giving
Yes. But I think being critical of that, maybe mild intellectual dishonesty is not consistent with what I just said about promoting people's agency and giving them opportunities to decide. Nor is it consistent with what I said earlier about making treatment compromises, even though they don't perfectly align with your black and white ideas of right or wrong things to do. So I'm gonna have to go home and privately reflect on that problem. One of the challenges that I've observed in clinical practice with time limited trials is that people often do appreciate some difference that they associate with the intervention. People love antibiotics, first of all. Second of all, there's a little bit of confirmation bias here, right? You're looking for a change associated with the intervention, you find one. We had a little tachycardia discussion just before this started. That's been detected by some people who are optimistic about the impact of antibiotics. The other thing is antibiotics are never administered in isolation, right? The one thing I mentioned earlier is always happening is the passage of time, right? Even if you do nothing but antibiotics, time still passes. Some people get better because of the passage of time, some people get worse. Usually we do other things too, though. Usually they're admitted to the hospital, they're given intravenous fluids, they start to receive helpful nursing care, potentially a bunch of other things that happen all around the time of starting an antibiotic that can cause a person to appear to be better.
I'm not a diagnostician, I'm a pharmacist. I've been around infectious disease long enough that I understand the diagnosis side of it, but I don't claim to be one. I think in this particular situation, in terms of just looking at it from, we'll say an outside observer's opinion, being that I am not a diagnostician, I would look here at what is happening globally with this patient. She didn't come into the hospital initially because of infection. She came in for failure to thrive and progressed to renal failure. And certainly that renal failure was a huge comorbidity onto this situation. What's keeping her in the hospital right now is not a possible infection in her graft. it is this ongoing failure to thrive and this renal dysfunction in all likelihood. And so, you know, looking at it from that way, then, you know, the idea that giving a trial of antibiotics for 3 to 5 days to show this is not going to change the trajectory of failure to thrive and renal failure becomes something to think about. But again, that's very specific to this case and not an application to other things.
So I keep going back to this phrase of do everything you can, which just looks incomplete, like do everything you can to do what, and all these sacrifices. I'm wondering, like, if we're just having a conversation with something the caretaker heard on TV.
No.
No, you were better student this than
Yeah, obviously do everything you can is not sufficient information. I think there's really good care literature about this phrase specifically, that I would encourage everyone to seek out, because it turns out that everyone who uses the phrase intends something different. Right, so some people mean do everything you can to prolong the biological life of this organism, period. That's usually how we act when we hear the phrase. But a lot of people mean do everything you can to restore my loved one to their previous state of health. And if you acknowledge that there's nothing you can do to do that, then this person's made a request that you can't possibly realize, and you haven't told them that you can't do it. Right? You have to just chop them out of the decision making because they told you what they want. It's not on the menu. You're never going to bring them a meal. You know, show them the menu so they can order food that you actually have. Some of them actually mean do everything you can to improve the comfort or quality of life of my loved one. Right? Very few people mean do things you can't do, because the word can is in there. So I think we start to describe this idea that these people are asking for the impossible. They're specifically saying can. They specifically want what is possible. It's on you to inform them of what is possible, and then to help them sort of choose from your possible options.
Any other questions? I'm gonna move forward, just for the sake of time. This is our last round of discussion questions, and it's getting at one of the things we think about a lot in microbial resistance and stewardship, and something that I think the ethics community is increasingly interested in and increasingly writing about, which as clinicians is always really interesting to see when this has become interested in something, because a lot of the samples they give are very sort, but you know, bacteria we know are passed from person to person, from sitting next to them, being in the same community, especially over repeated exposures. So in somebody who's been in the hospital, gotten a lot of antibiotics, we know their kind of general bacterial flora has shifted towards a drug-resistant bacterial type. And this patient's primary caregiver, her husband, is also elderly. He has a history of lung cancer and a history of C. diff. And chances are, if she were to go home, that they would be living in the same environment. And we know that her risk of C. diff is appreciable if she's on these antibiotics, and then that risk is conferred, especially with a family member who already has this history. So it raises this question that's somewhat unique to antibiotics, which is that we can focus on the individual, we can make recommendations, follow the treatment plan, but how do we account for the fact that that treatment plan could negatively impact the surrounding community, the immediate loved ones of the family, and kind of more globally, people that she comes into contact with, including nurses who are coming out once she offers decisions. So does that factor into your decision making for an individual patient, even if it doesn't have to do directly with their kind of immediate clinical care? Does it, and should it?
yes.
Yeah.
Yes.
Well, no, the answer for Kate is yes, and I actually have really bad news. It basically becomes your responsibility, Kate, not ours. So the clinicians, I think, continue to approach patients with the chief or exclusive focus being on the interests of the patient, and with not so much regard for sustainability as it impacts other people in the population. We will occasionally talk about sustainability as it impacts the patient, right? Some approaches to antibiotic use in patients who may have repeated infections over time are not sustainable for that individual. But I think it's pretty uncommon still for the clinician at the bedside to be thinking about community well-being or the future of the global microbiome when making antibiotic decisions. And that's why health systems have instituted antimicrobial stewardship programs to shift that responsibility away from the clinicians who can't easily take it on because it's in conflict with usually professional values, and to make it a systems level concern. And that's why it gets to be responsible for the fate of the
I
earth.
think that was partially my perspective when I was talking about the global outlook, looking at this particular case. But, you know, and if I'm called in at this point in time, which sometimes I'm called in at this point in time, you know, then you're talking about the risk associated to the current patient with her husband's background, but I'm looking at it both ways.
Yeah.
The patient in question is at risk to her husband, and her husband is at risk to her. Like the downstream effects of both now really become something that we need to take a good hard look at. Like, is this the right environment that we want to send the patient home in? So there's a couple things here that I want to touch on. One, there's a consideration to send her to a skilled nursing facility, which we also know stewardship in skilled nursing facilities and nursing homes is even worse. I won't use the term worse, but perhaps more lax, but worse because of their resources than it is within the hospital. And so you're adding a whole different element if she would leave the hospital, go to a skilled nursing facility first, and then transition to the home. Both the risk to herself, her husband, her, and such. That really needs to be evaluated. And then the other part of this is, you know, we are doing everything we can in terms of stewardship, and sometimes we do get a bad rap, right? You just want to tell me no, I don't want to tell you no. Like, I want to tell you no, yes, but here's the reason I'm telling you no.
It is way easier to say yes.
It's way easier to say yes. It's way easier to say yes, and I definitely became better at my job after I had kids because it's like practicing toddlers. You just keep saying no, and you keep having the conversation. No, you know, and here's why. And sometimes, you know, the explanation continues to fall on deaf ears, which is unfortunate, just because so many providers are just seeing the immediate concern, like, I need to take care of this person in front of me. And yes, you absolutely do, but we need to think about everybody else too. And there was just a paper published in Nature earlier this week, and it's all over the press right now. It's actually one of the main headlines on CNN. Superbugs are taking over, and the implications of what antimicrobial resistance are going to be by 2050 if we continue on the current trajectory is absolutely astounding. And so, in cases like this, it becomes an absolute risk-benefit discussion at the level of patients themselves, the patient and the caregiver, and then the community implications of all of this. And this is a prime example of where all three of those things need to be considered before you push forward with antibiotics in this case.
It's at least a little bit easier in this case because I would not be motivated to give antibiotics. So this becomes more like another justification for arguing no. And when that's the situation, I actually think it is appropriate to bring this justification to the patient or their families. I found that the patients are often interested in protecting their families from resistant bacteria. We create this anxiety in them when they come to the hospital, and we put them on like contact isolation for MRSA. First of all, they Google it and they're like, oh my God, I have MRSA. Do I die? Usually not. But second of all, we treat them like they're incredibly dangerous to us and to fellow patients. And then we send them home with absolutely no guidance on things they could do to protect the people they actually care about, which are not us, but their spouses, their children, their grandchildren, right? We give them no tips about that. And really the tips we would give are like, man, don't bother. You know, which seems weird from the people who've been prancing around in these yellow gowns for their entire hospitalization. But I think if you're in a situation where you're working with a patient to make a kind of global informed decision about antibiotics and you don't feel strongly from a clinical perspective that they should be treated with antibiotics, you do have the opportunity to talk with them about how their decision-making affects the people close to them and might affect the community in the future. I'm not sure that I would be able to do that if I felt strongly that a person was likely to benefit from treatment with antibiotics, which is the tricky far end of the spectrum here. I think this is Chelsea's take too, though. I think there's enough antibiotic use out there that doesn't benefit patients and that we could probably work on that first to spare ourselves the ethical challenges of weighing patients' well-being against communities. But at the very end of the line, that is the last final frontier.
And it seems like, correct me if this is just my interpretation, it feels like there's this disconnect, right, where we have mainly infectious disease providers who are, the stereotype is that we're kind of doomsday people. We're predicting this future where there's a pan-resistant bacteria that's just gonna kill everybody. But we have increasing data to suggest that, this is a kind of catastrophic issue. But there's this disconnect between this being a collective problem and individual prescribing practices of individual providers and patient scenarios. And so I was curious, if either of you guys have had success or like challenges in kind of communicating the link between an individual prescriber's actions and this kind of doomsday prophecy that everyone rolls their eyes when ID doctors start talking about.
I have not had any success in that with Chelsea.
Other than just saying no.
I have not either. But in this case specifically, you can make a really good argument that we created this problem. So, the initial case noted chronic aspiration, she had several 7 to 14-day courses. If somebody aspirates, they're no really bad for 24 to 36 hours, but they're not necessarily effective. And trying to talk down the provider to say, just watch them for 24 hours. I promise you tomorrow at this time, they're going to be okay. When again, they're looking at the immediate thing in front of them. And then, so they start antibiotics. If they respond really fast in 24 hours, take them off. And they do. And they're like, antibiotics made them better. Fix it. And that's why they're now growing that awful gram-negative rod on their skin. Because we have probably colonized them with that from all of the selective pressure that we gave them. And so, this is a prime example of us doing this to somebody. And I think we're gonna get to the point where we are going to have those hard conversations with some of our providers. Olivia has some time, right?
What do you think about the possibility of this being malpractice? And physicians being held accountable for antimicrobial resistance that might be a consequence of unwise antimicrobial choices. I'm speaking to the only attorney I know.
Yeah, that's a tough one. Usually it's like causation issue, right? So you have to demonstrate that kind of causal relationship here. That can be tricky. It's not entirely clear in this certification piece that sort of the duty of care in this context is fully formed and constructed in a way that there's a consensus and a standard there. I hear there's guidelines and all of that, but on these tough cases, well, maybe this is on the tough cases, right, where there's disagreement about what the right approach should be, that's where the puzzle sort of argue case.
Just relatively insulated.
Yeah, no,
Well, it sounds like we could probably establish a causality, but there certainly is not an intent. Like there's no intent to cause harm or negligence. It's fine.
Yeah.
Instigation maybe for the standard of care, not at this point, but at earlier points in the.
Yeah.
That's what I know this isn't law for lunch.
All right, I'm gonna leave the last 7 minutes here, so just any reflections, thoughts, questions to.
I have a question. So you talked about difficulty saying no to provider or prescribers.
I don't have this.
You know, yeah. Potential folks do. Could that also be at play? Is there sometimes a difficulties in patients? And how do you navigate maybe a prescriber that does have difficulties saying no, or does that situation, maybe their personalities is under the pressure there? How do you navigate that?
The example.
I know. That's accurate, yes.
But we won't name, and that's not how this works. Yes, it is, I think at times difficult to say no to patients. It's even more difficult because of the other providers are our colleagues. They're subject to the same sorts of rules as we are. I mean, it's not the exact same sort of rules or values. There's even say like, look, dude, this is the rules. But you can't really say what to a patient almost at all. And it's hard to talk about things that are your values and your interests and your commitments when the patient is asking you for help for themselves. So you're kind of limited to ways that you can express how the decision you're making now reflects care for the patient. And that's why it's not always easy to do that. Right, it's pretty easy from the patient's perspective to think most people who receive this antibiotic do not experience a complication. Usually the patient's already received that antibiotic hundreds of times before in their life. My other doctor gave it to me every time I had a stuffy nose or whatever, and nothing bad ever happened. And so I'm withholding a treatment that they expect to get or are accustomed to getting from someone else, and the justification I'm giving is not always very convincing. And I think the only way to fill in that blank there is to become even more accessible for feedback and responsive to new information. You can't say no and then stop and say no.
Here's one.
But if something changes, here's how you reach me, here's how we make the decision to use the treatment that you're seeking potentially in the future, right? Then absolutely no, usually it's not going to be very far.
Like I said, they have kind of looked at this, especially in primary care settings where you have providers who are not necessarily go through extensive training in infectious diseases, but do prescribe antibiotics on a regular basis. And they've actually been able to show that a lot of the times it's not actually a patient-driven request, but it's the provider's perception that it is a patient-driven request that results in an antibiotic prescription. And so just kind of getting at the complexity of the patient-provider relationship, a lot of times it may not necessarily be even a patient-centered decision, but it may be just kind of this perception that antibiotics are expected. So when you think about where a potential intervention could be, it still kind of ends up being provider-focused rather than patient-focused, at least here in the US.
So we've got this problem of misuse of antibiotics and the flourishing of superbugs, antibiotic resistant bugs. And we've got this solution of good stewardship and reducing misuse, but it seems like that's not working. Is that a viable solution? Is that ever going to work? Or should we be looking for a different answer or changing the way we do that?
So I'm hesitant to say that it's not working yet.
Okay.
I think we can say that in some facets it's slow. In hospitals, it is slow. We have here at Hopkins a very aggressive stewardship program. We've had one since 2005. Not very many other hospitals were on the stewardship wagon as early as we were here. A big help was in 2017, the Joint Commission said, as a condition of accreditation, you must have an antimicrobial stewardship program. And so hospitals are slowly coming online. And I think that in that aspect, we are doing okay. And as these changes have come forward, it started in inpatient first, now it's moving to outpatient. One of our new projects is actually perhaps looking at a provider level and looking at the number of antibiotics a provider prescribes and then going through them in a targeted interventions, which is a little scary. But again, I have to keep telling myself I can say no, right? And so, but it does go back to what Chelsea said, right? The expectation when a patient comes to your office is you're gonna give me a piece of paper and I'm gonna go to CVS and I'm gonna get something that's gonna make me feel better. And so that's a large part of it, where I think we need to do so much better is antibiotics in the environment. That is where a lot of the harm is coming from. And so if you look at global consumption, what's used in hospitals is only about 5% of all antibiotic use worldwide because of global use of antibiotics in agriculture, environment and such. And so that's where the next step of the work really needs to come from.
And success can only be slowing the emergence of
Right.
antimicrobial resistance. There's no success on the order of stopping the emergence of antimicrobial resistance. It's an evolutionary reality that it's going to be happening.
Do we need science to say this?
No, science keeps trying, right? Science keeps making us new antibiotics. Science is not gonna stop evolution.
It's over.
We're not. We're losing, but we could lose more slowly.
That's the dream. I'm hesitant to end on that. We are out of time. So thanks everyone for